Welcome, everyone. My name is Amit Arora, and the remit I have today is to talk with you about the coronavirus disease. As Lisa says, please switch off your microphone so that there is no disturbance in the background, and do not share your videos because then people won't be able to see the slides in their totality. So I'll talk a little bit about what the slide set is. As you all know, that things are changing on a daily basis, and new experience, new data, new evidence, new guidance is coming out frequently. So whatever is true today may not be true tomorrow. The slide set was made about last week, and since then I've already made some changes and incorporated more recent guidance. Uh, but do keep an eye on the latest developments. Some slides in this session have been kept deliberately long, busy, and detailed. And the reason for that is in doing that, you will have every information that you need at hand rather than trying to look for everywhere else. So, with that in mind, I'm going to make a start. But before I do that, the one other thing is there are a variety of people on this call. So there will be doctors, nurses, healthcare visitors, care home staff, people working in primary care, community care, acute care, etc., etc. So there will be. It's very difficult to pitch to everybody's need when in one single session. So feel free to pick up whatever is relevant to your role because not everything will be relevant to you. What I'm going to talk about today is to go through some basic information about the COVID and determine what do you need to do a basic respiratory assessment. How do you manage a patient with COVID in various settings? What can you do yourself, and when do you refer to somebody else like acute hospital, etc.? What else can you do for those patients who are approaching end of life, and also importantly, how to stay safe yourself and how to keep your own family safe. And I'm hoping that in doing all this, I'll help you to be prepared for some of the challenges that you may face in the next few weeks. So, what is coronavirus? So, coronavirus is a common family of viruses. As a medical student, many years ago, I read about it and I thought it was a common cause of cold and nothing else since then. And it made a comeback in December 2019 when a new strain emerged. The new strain is called Severe Acute Respiratory Syndrome Coronavirus 2, in short SARS-CoV-2, and the disease it causes is called COVID-19. Now, there is some assumptions that there could be more strains with varying levels of severity, and they affect different population groups in different countries in a different way. But we will know more about it in the next few months when all the data is out. The disease is rapidly progressive and the numbers are sharply increasing worldwide. As of earlier today, 1.4 million have tested positive, with over 60,000 in England and UK alone, and over 89,000 patients have died worldwide. So it is quite serious. Of course, it was declared as a pandemic by the WHO last month. So, what does the virus actually do? So, when the virus enters the body's cells, it goes into the lung epithelia. So, this is the normal structure of a lung. So, this is from the nose. This is the trachea here. This is the main bronchi, and then it divides into bronchioles. And if you look here, this is the end of the lung side, lung circuit, if you like. At the end, there are these alveoli which are filled with air. When the virus infects, it causes an inflammatory reaction, and this air is then replaced by pus and fluid. As a result, normal air cannot actually go into the alveoli, and so there is no exchange of gases, i.e., oxygen and carbon dioxide. So when people can't breathe or exchange oxygen, then they start to get short of breath. And as this progression of inflammatory collection worsens, people tend to develop a pneumonia. And that's what the basic pathophysiology is in this disease. As the pneumonia progresses, it can lead to further complications. So pneumonia can be a non-severe pneumonia and may not need oxygen. It can be more severe pneumonia, which is characterized by fever in the presence of a respiratory infection with respiratory rate of more than 30 and oxygen saturation of equal to or less than 93% on room air. As the pneumonia worsens, it could lead to sepsis and septic shock and eventually translate into acute respiratory distress syndrome. Or some patients may develop acute cardiac injury because of viral myocarditis, eventually resulting into a multi-organ failure, sometimes but not always superimposed by a secondary bacterial infection. And it's the ARDS or the multi-organ failure which leads to the death of patients. So under normal circumstances, when a patient presented with cough, fever, or shortness of breath, you would normally think about normal known conditions like COPD, asthma, emphysema, cardiac failure, pulmonary embolism, pneumonia, sepsis, etc. In today's context, with somebody presenting with fever, cough, or shortness of breath, it's almost certain, unless proven otherwise, that it is COVID related. However, you should not assume that it is only COVID related, because cough and fever can still happen without the presence of COVID, and sometimes heart failure or pulmonary embolism could even present with shortness of breath. So I was seeing some patients a couple of nights ago, and we saw somebody with a pulmonary embolism who had presented with shortness of breath. The only sign that led us to think that it was pulmonary embolism was because this patient had had a foot surgery about 4 to 6 weeks ago. So that was a pointer towards pulmonary embolism. The point I'm making is that we shouldn't assume everything is coronavirus related, because there may be other pointers which may tell you that, well, it is actually COPD, worsening of COPD, or acute exacerbation of asthma, or a worsening of cardiac failure, as would be characterized by, let us say, cardiomegaly and increasing leg swelling, or a raised JVP, etc. So if we focus towards coronavirus, the chances are that the symptoms present between 5 to 11 days after exposure to somebody with known coronavirus disease. Now, the difficulty is that you don't really know when you got exposed to the coronavirus. So as a general rule, around 5 to 11 days after exposure, the symptoms are similar to seasonal flu. Majority of patients have fever and dry cough, which is generally of rapid onset. Symptoms will last 5 to 6 days generally. After day 7 is generally when the severe illness starts. And that's the cause for concern, that patients who do not start to improve after day 7 should seek medical assistance. Okay, right. This is normal disease progression as seen in the Wuhan data from China. So if you look at the slide here, a lot of patients presented with fever, which lasted up to 10 to 12 days. Fever was almost always accompanied by cough, which lasted till about day 19. Shortness of breath generally appears at about day 6, 7. By about day 9, they tend to deteriorate because the pneumonia gets worse, translates into sepsis, acute respiratory distress syndrome, and leading to admission in intensive care around day 11 or day 12, depending on the severity. And what we have also seen is that in a lot of patients, fever is not the presenting symptom. And we will see in the slide later that fever can only present in about 45% of patients, but is present at up to 88% during or at hospital admission. So this is the data from Wuhan, China, which mentioned that the median age of patients was 47 years, with 42% of females and remainder were males. If we look at the Italian data, the majority of patients affected were males, 80%, whereas only 20% were females. And we all know that it is more serious in older people, and this is confirmed by the fact that 75% of all deaths occurred in the population above the age of 70 years. Now, I'm calling this as an approximate statistics because, and the reason I'm using the word approximate here is we actually do not know what we do not know. So these are the unknown unknowns. So these are the ones which we haven't even tested. So we don't really know how many in the community are untested but suffering from coronavirus. So if we focus on the tip of the iceberg here, so these are the tested and the confirmed ones. And the reason we do not really know is because there are variable levels of testing worldwide, and what UK has adopted in terms of testing may not be true for what Germany or Australia or USA have adopted. So that's why you see variable levels of numbers in terms of how many patients have got the illness. Despite the number of patients who've got the illness, what we can say is approximately 80 to 85% of patients will have mild disease. With mild disease, their symptoms will be still fever, cough, muscle aches, sore throat, red eyes, fatigue. 20% of patients will have severe disease. Many of these will get admitted, and this will include pneumonias, respiratory failure, and sepsis. Only about 3 to 10% of patients do get intubated, of which about 2 to 5% of patients will die of causes related to ARDS or multi-organ failure. Now, one can debate that many of these patients may not be alive after 6 months in any case, irrespective of whether or not they had coronavirus disease, but that's a different debate. There is some good news in this doom and gloom, which is that children seem to have some kind of a resistance to the disease, and there are some scientific explanations being explored around. Coming to the transmission, how does the virus get transmitted? So there is wider consensus that it is transmitted through exposure to large respiratory droplets. So if somebody is coughing and sneezing and you catch those respiratory droplets, which can go as far as 2 to 6 meters, depending on the size of the respiratory droplets, then you could be exposed to the virus. It can also be transmitted through touching some contaminated surfaces, and there is various data as to how long does the virus survive on plastic or paper or wood or glass, etc. There is some evidence that the virus can also survive in the air, although the current guidance is that it cannot be transmitted through air. But this is something which could actually change soon. We're not quite clear worldwide as to exactly whether this may or may not be a route of transmission. And because of the various routes of transmission comes the policy of avoiding close contact, i.e. stay away for more than 2 meters, which is the distance which is generally required for transmission. So when you encounter a patient with suspected coronavirus disease, and it can be in various settings, it could be in your mental health wards, it could be in your physical health wards, it will be in a community care setting, i.e. a home, a care home, a residential home, nursing home, patient's own home, assisted living facility, or wherever else. So patients are generally quite anxious when they think they might have COVID disease, and to be fair and quite rightly, we may ourselves be quite anxious about seeing a patient. So you need to explain to them and approach them calmly and gently. In your initial assessments, there are a variety of things that you could look for. So that might include, are they warm and well perfused? Are they sinuous? Can they talk in full sentences? Are they comfortable? Ask them about their breathing problems. Are they normally this short of breath, or this is significantly worse? Ask them about their cough and whether they are actually able to clear any secretions, whether they can dispose those secretions appropriately. We'll talk about swabbing later, and we'll have a look at the chest X-rays later. Um, and we'll talk about all these things a bit later on in terms of oxygenation and treatments and things. Okay, so if we did some tests, what will we find? Majority of the times there are non-specific changes in the blood tests, so it's not a very helpful guide, at least in the initial stages. In the initial stages, you might still find slight reduction in lymphocyte count, slight elevation in white cell counts, but as the disease progresses, almost everybody will have a high CRP, sometimes between 30 to 40, ranging up to slightly above 100. And more importantly, if they have a very severe disease, then it could go even further beyond 200, for example. In more later stages, other markers, LFTs, D-dimers, ferritin, ESR, those could also go up. But what we are mainly concerned about is the early stages in which only the lowered lymphocyte count and a higher CRP may be your only indication. So in some ways, blood tests are not that important in the diagnosis of coronavirus disease, although they may have some more usefulness in terms of determination of the progression or recovery from disease, and that might help you in escalation and de-escalation. We'll talk about those later. So coming on to the chest X-ray, it can show a variety of things. It can show a normal chest X-ray to a very severely compromised X-ray, or somewhere in between where there is pneumonia on this X-ray, both sides. A scan, a CT scan, which is a section here, is showing pneumonia on both sides, and some patients may even show thromboembolic phenomenon in the chest X-ray, in the CT scan, and also some early fibrosis. I want to talk a little bit around the News 2. Many of you may be using this News 2, so it's the National Early Warning Score 2. This is developed by the Royal College of Physicians and is adopted in NHS, but also used worldwide in a lot of places. It basically comprises of 6 simple physiological parameters which form the basis of the scoring system to warn or alert staff as to that they need to do something about the patient. So what are those 6 parameters? So respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion, and temperature. So if you look onto the other side of the screen, if you look over here, so it mentions the areas in the white. So in this instance, in terms of respiration, anything between 12 to 20 is in the white section, which is the normal, and then you go on to the yellow and the orange bits, which are the abnormal bits. So based on what your readings are, every bit of parameter gets a score allocated. And based on those scores, you determine what is the severity, what is the frequency of clinical monitoring required, and what is the urgency of clinical review. So all the 6 parameters are mentioned here in A, B, C, D, E. And when you calculate a total score, you come to a scoring system like this, which is already on the phone. So a News 2 score of less than 5 means ward-based care, so continue to do what you're doing, but no need to send patients anywhere else, but do ask for some support. High scoring single parameter is odd. Look for a reason. With this, I mean that if a single parameter, let us say, for example, pulse, parameters are within the normal range, so there must be a reason related to the pulse. So have a detailed look what's going on. Is this atrial fibrillation with fast ventricular response, rapid heart rate, or something different? And the same stands for rest of the parameters, that if there is a single high scoring parameter, look for a particular reason. Use of 5 or more is concerning, and you need to start thinking whether this patient has got some kind of sepsis. That might include coronavirus, but other causes of sepsis may also be there. And finally, the News score of 7 or more is a major concern. and it calls for a urgent or emergency response because the clinical risk here is high. Under normal circumstances, that immediate response would mean a blue light from the community. In COVID times, it may be different because not everybody may be suitable for the blue light response or a hospital admission, and that's why it is important that we plan the escalations early on in the exposure to the patients. So, and we'll come on to that in a minute. Many of you work in the non-acute ward settings. And for those settings, there is a 3-page flowchart, which I'm not going to be able to go in details because of the time. But these flowcharts will be available on your non-acute wards, whether you are working at the Haywood or the Redwoods or St. George's site or somewhere else. And similar adaptations can be done in the community settings, but you'll have to make your own clinical judgments based on whatever has been mentioned here. And these 3-page charts actually explain to you what to do in a suspected case, how to identify a patient who is deteriorating or who is critical, and these are based on the News 2 scores. And most of the inpatient settings that we have now will have the News 2 already rolled out in those settings. It also mentions around the treatments, what are the desired outcomes, and what do we do in terms of escalation. And in terms of escalation, it also mentions around clinical escalations as well as management escalations. So it's a fairly comprehensive chart. And this bit here also details about what to do, when to do, how to determine whether the patient is improving, and what to do when the patient is not improving. So these are available on your wards. If not, they will be, but equally this presentation in terms of slides and download will be available via a link, so feel free to download that and use these. Okay, so this is again similar, and then I think it will be useful to read a little bit around what to do after a patient dies. So that's the important bit. Okay, this is a new addition which we have just added in the last 48 hours or so. So it has not yet percolated into the system. But the reason for this is that a lot of patients will now be on the Haywood wards and Redwoods and St. George's sites. So this is just a guidance to a lot of colleagues as to what should be the process of the ward round. So, and I'm not going to again go into a huge detail, but it identifies what are the things that you should do before you see the patient. And these are simple things like wear your PPEs, make sure that the patient has got one, maintain the bare below the elbows approach, maintain appropriate hygiene in terms of hand wash, etc. If you are going in a bay full of patients, only one person should go into the patient for direct contact. Do not take the notes trolley or the patient's notes into the room, and those kind of things. What are the tests that you could do? What to do when you are with the patient? And then there are some treatment guidances so that you have a basic idea of what are the main things of patient treatment. So if I just very quickly run through some of the things in terms of patient treatment, so there's something around oxygen, so try and maintain an oxygen saturation of so and so, and this is going to be revised. So by the time you download, so please do not download it in the next hour after this, because we are waiting for some bits of confirmation download afterwards. So one of the key things is, for example, manage the temperature with paracetamol. Do not give ibuprofen. In terms of fluid balance, the key thing is to do not overload patients with fluid, even if they are mildly dehydrated, because more fluid can cause more problems into the lungs, and the full science behind it is not fully understood yet, but that's what is being experienced clinically on a day-to-day basis. And then there's something around steroids. So do not use steroids unless it is for bronchospasm or patient is already on regular doses of steroids. Then there's something around tazocin, that if you're something around use of antibiotics. Not everybody needs antibiotics, but nobody is going to penalize you for using antibiotics if you were to suspect there was a bacterial element to their infection. The common guidance at present is use the community-acquired pneumonia guidelines and and stick to those. Tazocin, which is widely used, does not have any extra additional merit over the use of amoxicillin or augmentin, etc. There are some generic things so that you hold the nephrotoxic medications and similarly if you come here, so try not to use the nebulizers and try to use spacer with the inhaler device so that you're not producing a lot of particles outside. There is no role for routine use of saline nebulizers, for example. And there is a lot of thing around general good clinical, medical, and nursing practice, so maintaining nutrition, hydration, bowel, catheter, pressure care, cannula care, etc. And do not forget the thromboembolism prophylaxis, so which would be the, for example, deltaparin for thrombolysis prophylaxis. You could use some N-acetylcysteine or erdostine in terms of oral mucolytic agents. So there's a lot of guidance around that. I would draw your attention around escalation and de-escalation. So in terms of when do you move patients from your ward to from a COVID ward to a non-COVID ward, or when do you move a COVID patient to a different area and around self-isolation. So a lot of information is in this. So feel free to have read of this. This is some national guidance around oxygenation, which I will leave you to decide. But as a general rule of thumb, guidance, 90 to 92% of oxygenation should be maintained. If you're giving oxygen and if you reach 4 liters of oxygen per minute, then that would be the time to escalate it to somebody else. So, i.e., if you are working in a community setting, in a care home, or in a community hospital, the patient is reaching, not maintaining oxygen saturation of 90 to 92%, then it's better to escalate early on and you could discuss with the acute sector and they will need to make a decision whether they want to increase the oxygen or use a CPAP machine or some other machines, i.e. ventilation, etc. So that's something to escalate. Okay, so we've talked a little bit around the treatments already, but essentially do not forget the news tools and the ABCDE scores. You could use the paracetamol as antipyretic for fever control. I want to say a little bit around the various newer things that are coming. So some drugs are being trialed. So those are the antiretrovirals which are used for HIV, vitamin C high dose, hydroxychloroquine, azithromycin, and some other medications, including plasmapheresis, etc., are being tried. And as the name implies, these are only being tried and should only be used under trial purposes at the moment. So in the UK, at present, none of these is licensed for a non-trial use. This is slightly different from the policy that was adopted in China, in which they used chloroquine and high dose of vitamin C. Americans are also using high dose vitamin C up to 1,000 milligram intravenously. India has approved the use of hydroxychloroquine for prophylaxis, but these are isolated things, and currently these are not for use outside of clinical trials. There is an antigen test which is already available, which is different to the antibody test, which may be available soon. With soon, I mean within hopefully the month, but we will know a little bit more about this. So the difference between the antigen test and antibodies test is this. So antigen test tells you whether or not you have COVID disease at present. Antibody test determines whether or not you've had COVID disease before, and and if it is positive, means you may be immune to the COVID disease. So there's a big difference. Antigen test is, do you have it now? Antibody test is, have you had it before? So that simple sentence should identify what the difference is. We have antigen testing available. We should have antibody testing available soon. And then is the issue around vaccine. So currently there is no vaccine available. It may, however, be available, but it's at least 12 to 18 months away for public consumption. I want to say a little bit more about oxygen, which is the mainstay of treatment for COVID disease. And as I mentioned earlier, that if try and maintain oxygen saturation between 90 to 92%, where although the national guidance is above 92%. There is some local variations in various hospitals for a variety of reasons. And follow your local guidance. That's one. And then the second thing which I want to say around oxygen is that if a patient is requiring more than 4 liters of oxygen or 4 liters of oxygen and are not maintaining their saturation, then do ask for help from the acute sites, and also consider whether the patient is for escalation to intensive care, etc., or not. And then the third point I would want to make around oxygen is the range of 92% is for patients who do not have COPD. For patients who have COPD will not need that much oxygen. Their range should be 88 to 92%, which is their normal maintenance of saturation. If we give them too much of oxygen, they could actually deteriorate. And that's why it's important to remember that. And finally, on this, there are certain oxygenation procedures which are classed as aerosol generating procedures. I'm not going to talk into them right now, but for you to be aware that there are certain oxygenation procedures which are classed as high flow, which are classed as aerosol generating procedures. However, at present, in none of the mental health wards or Hayward Hospital wards, we use any of those. So you don't need to worry about that. Okay, there are certain things which are worth mentioning around signs of deterioration. So in whatever setting you are working, be mindful that the deterioration in COVID patients is most likely to occur in the second week of infection in those patients who have not improved within the first week. That deterioration may be fairly rapid. Again, it is caused because of sepsis and acute respiratory distress syndrome and may require hospitalization, generally for oxygen, but sometimes for CPAP or ventilation, which are another ways of providing oxygen therapy. Some patients may develop acute renal impairment or simulate a heart attack type picture presenting with chest pain, but this is largely because of the viral myocarditis that they might develop. And then again, signs of the deterioration on the News 2 scoring, but other signs may also be available to look out for, which include reducing renal output, temperature is low or very high, cold hands or feet, identifying poor circulation to the peripheries, blue lips or face, identifying cyanosis, which means oxygen saturation will be less. A skin mottling generally appears in the lower limbs first, patients coughing up blood, or there may be developing neck stiffness or a rash, which may be a sign of viral meningitis. Again, when you identify somebody with sepsis 6, in whichever setting there may be, there are 6 things that you need to do. So those 6 things include 3 things that you need to prescribe and 3 things that you need to check. So the three things that you may need to prescribe are oxygen, fluids, and antibiotics. So we've talked about oxygen, we've talked about antibiotics, and then comes the fluids. So fluid has to be given carefully, aim to achieve a neutral fluid balance if you are giving it in a ward setting or outside of the ward setting. There are three common fluids that we use. So normal saline, 5% dextrose, and Hartmann's. So normal saline and Hartmann's are okay to use in general. Most of the patients, in patients who have got hypernatremia, high sodium levels, do not use normal saline, and patients who are diabetics do not use 5% dextrose. There are three things that you need to check. One is a blood culture, so you can take some bloods off and send for blood cultures, hourly urine output, which you could measure, and finally blood gas for lactate. Now, blood gas for lactate is not available in the community setting, so I would ignore that. So I don't think you should get too worked up for those things, for the things that you need to check, but at least if you can give oxygen, fluid, and antibiotics where appropriate, or arrange for those so that the patient can be moved to a appropriate setting, that would be the thing to do. I'm going to have a sip of water and then I'll resume. Okay, so what happens when the patient comes to the emergency department? So the emergency department currently and across the country is nowadays divided into two areas. So one is a red area, the other one is a green area. So the green area means which is a clean area, which means patients there are not suspected of having COVID-19. Red area is for patients who have got suspected COVID-19 patients. Okay. In our local patch, there is a primary care hot hub, and I think most of the country has kind of developed some of these COVID hot hubs in primary care, where they're also seeing some suspected COVID patients or some confirmed COVID patients, largely speaking by telephonic communication, but sometimes face to face. This is a guidance from Public Health England, which we have largely kind of more or less covered, that if you're suspecting somebody who has got COVID disease and if they need to go to secondary care, then there are certain precautions and some PPE, etc., to be worn. And these are patients who are on the different tracks. So if patient has got COVID-19 symptoms but are well enough to remain in the community, and they may still have high temperature and new continuous cough, then the guidance is to stay at home for 7 days. And if there is no improvement of symptoms at the end of day 7 of isolation, then go on the NHS 111 website, in preference to ringing NHS 111. So you could do either of the two things. I've looked at the NHS 111 website. It's very informative and can give you some quick tips as to what to do, and also some tips around staying at home. This is from the British Medical Journal. I think most of this we have already covered. We are not covering GP surgery here because we covered the hot hubs. This is around self-isolation, and because we haven't covered self-isolation yet, that's why I'm going to talk a little bit about this. So self-isolation, patients who are self-isolating are those who have got mild symptoms, which might include some fever, cough, and shortness of breath, but they are not acutely unwell, and they've been advised to self-isolate. So what are the things or what advice can you give to those people who are self-isolating? So they should stay indoors, separate from the rest of the household for 7 days, in a separate room, preferably with an attached toilet. They should have their own cutlery, bedding, crockery, etc. And also if they are disposing of something in terms of their waste bag or bed sheets or clothes or whatever else, then they should be putting those in a double bag waste and keeping it for 72 hours or more away from the usual household disposal bins. Okay, right. So now this is from the Royal College of Physicians guidance, and it largely talks about things that we have mentioned. And I think the key thing there is for those outpatients who are self-isolating at home, they should be separating themselves from other household members and animals. And you may have read recent reports from some countries where they've noted that some animals have also been infected. So that's something to be aware of. And of course, then there is the usual disinfection of frequently touched surfaces, which is important. So whether those surfaces are your water bottle or your mobile phone or your stethoscope or your pen or your desk or the bin handle or different things. So they need to be disinfected. We are not using a test-based strategy in terms of home care at the moment in this country. So for that reason, I'm going to skip this slide, but I'm going on to the slide, which is the next slide, which is what we have adopted in UK, is a non-test based strategy. And what it means is patients may discontinue home isolation when the following criteria are met. So these criteria are: at least 7 days have passed since symptoms first appeared, and at least 72 hours have passed since recovery of symptoms. And recovery of symptoms is defined as resolution of fever without the use of fever reducing medication. So this is the important bit. So 72 hours have passed without the use of paracetamol, and improvement in respiratory symptoms, that is shortness of breath and cough. Now, I would want to say here that cough can actually last for 21 days. So as long as it's improving, then that's fine. The next bit is the hospital-based care, which we have already discussed in reasonable detail. So I'm not going to go and keep on discussing this because we have limited time for this. I do want to say a little bit around those staff who are working in care homes. So there are 2 or 3 bits of pieces of information for care homes. So one is for our operational team members. So the operational guidance to care homes is out. Care homes are aware of this, and the local authorities are aware of this. So it also mentions that care homes should remain open to new admissions as much as possible, and they should be prepared to receive back care home residents who are COVID positive and to isolate them on return as part of efforts to ensure capacity for new COVID cases in acute hospitals. And this nicely links in with the de-escalation plans that we mentioned earlier on in our ward round checklist. And finally, the care homes should also be able to take patients with COVID negative back when they are coming from a COVID positive hospital back into the care home. So they should be following the public health guidance in those situations. In terms of clinical colleagues, there are 2 pieces of useful information. One, the patients who are in care homes, they should be supported by the healthcare system, and that might include advanced nurse practitioners, doctors, GPs, other practitioners in terms of making decisions about end-of-life escalation or anticipatory care. And also that they should have enough stock of anticipatory medications and prescription charts, oxygen, etc., to ensure that patients who are for palliative care in the care home, their needs can still be met in the same care home without the need of sending them for acute care unnecessarily in circumstances where a decision has been made. Right. If you have a quick look at this while I have a sip of water. Okay, so some of the things we have already covered, but this bit here actually explains that patients who have got no symptoms are less contagious than patients who have got critical symptoms who are more contagious. And this relates to the viral load, that the patients who are more exposed to an increased viral load will have critical symptoms, they will have worse outcomes, they will be more contagious. People who have got less exposure to the viral load, or patients or such patients, they may have no symptoms, they may be more immune, they may be less contagious. So this all relates to how much exposure is there. And I think the percentages, again, from this study are very similar. 80 to 85% will have either no symptoms or mild to moderate symptoms, whereas 15-ish% patients will have severe or critical symptoms, which may require hospitalization, and some of those patients are the ones who will die. I think we have covered the prognosis in a reasonable detail in the previous slide, but these are some of the risk factors for severe disease. Older ages, people who have got coronary artery disease, those who have diabetes, high blood pressure, COPD, cancer, and also there is some question around obesity as a potential marker of a poor prognosis. Although it affects large older people, it is not to say that younger or healthier patients are immune to this. We all know that there are younger people who have had the disease and sadly died as well. Now, there's only one comment that I'll make around ventilation. That ventilation, yes, it's useful, but it's not to say that it is always successful, because even after ventilation, survival rates may not always be high. Okay, I want to say a little bit around future care plan, and this is more relevant for those patients who are in care homes and are already approaching end of life. And these are the patients in which earlier conversations will benefit both patients and their families. And there is some nice rapid guidance around this, which I'll talk to you about. If the patients are for escalation, then call the critical care outreach teams or acute hospital sector. If the patients are not for escalation and if they need palliative care in whichever setting they are, then you could use some morphine, some oxygen, and some sedation as appropriate for palliative care. And for this, please do contact the palliative care support team or the BNF for the right kind of doses as and when appropriate. Talking to relatives is a bit difficult and different from what we are all used to, because we are used to talking to relatives and families face to face, but current situation means that we may not be able to do so in every case. So it is a bit more sensitive, it is a bit more difficult, and even the DNA CPR decisions may have to be made by phone calls, and be prepared to be able to do that. And you may want to think about how to do that. And there is some guidance around this from Chelsea and Westminster Hospital, which I found reasonably useful. So have a look at that in your time. Many of you may be using this RESPECT document already. Many of you may have just seen it and not used it. So this basically explains how you can make some kind of decisions around their preferences and how we can implement those and how we can then seek the support of palliative care teams. These are very difficult decisions, and NICE, which is the National Institute of Clinical Excellence, has produced some guidance around how to make such decisions. That guidance works in conjunction with the clinical frailty scale, which some of you may have used, but if you really look at it, it's quite pictorial with some description on this side. So you could actually determine the level of frailty of these patients. 1, 2, and 3 are not frail, 4 is vulnerable, and then 5 till 9 are in the frail category with varying severities. So what does the NICE guidance say? So it's classed itself into CFS score of 5 or more, or 5 or less than 5. So this side on your right is scores of 1 to 4. This side is score of 5 or more. So let's say, what does it say about four or about CFS of less than four? So make a plan, let them be treated on the ward. If the condition deteriorates and if they are for escalation of treatment, refer to critical care. If their clinical frailty scale is scoring more than 5, make an initial plan, manage them on the ward. If their condition improves, continue on the ward. If they are for escalation, as you've already made a decision there, then escalate them when their condition deteriorates and refer to critical care. If you think that critical care is not considered appropriate, continue to manage on the ward. If the condition deteriorates, implement end of life care. And that goes back to our respect document and what can you do in terms of implementing end of life care in the care setting that the patient might already be. Many of you will be doing some swabbing. Um, and those people who are involved in doing swabbing already know a lot about it. Those who are not doing a lot of swabbing, there is a very quick guide which you could have a quick look, but basically rub the swab across the tonsillar areas. Oops, sorry. Okay. Specifically targeting any inflamed areas, but I think most of you who are doing swabs already know, but there is a lot of guidance around swabbing, so have a look at that. And then how do you send the swabs? There is again guidance around that. How do you dispose of the waste? Again, some of you may already be aware, so it needs orange bag for clinical waste, which is category B, infectious clinical waste, and the black clear bag, which may also be used for domestic waste. PPE. Now that's a really, really sensitive and a difficult one, and I think quite rightly there has been a lot of issues around PPE. There was a previous guidance from Public Health England which was changed about a week or so ago. Most of you will be aware of the new PPE guidance. It is also available in the trust bulletins. And I think what I will say to people is use the public health guidance and use the appropriate PPE. There is no shortage reported in our trust for PPEs, so feel. But if you do speak with your own line managers, and they should be able to sort the thing. So okay, so there is guidance around this in terms of primary care as well as community care, and then there's a separate guidance for use in secondary care. It depends on which area you work in. This is a very good pictorial made by one of our own colleagues within the trust, which was then adopted by Public Health England, and it actually details what PPE is needed. It's too detailed for me to go into details, but I'll say a couple of things here. The things that you might be more commonly exposed to in your day job is either some dental procedures which are currently not happening anyway, or sputum induction like in chest physiotherapy, or in situations of CPR. So there is a slight difference in the guidance from Public Health England versus the Research Council. I would go with what the trust says. I would also recommend you to go on to the YouTube video to see the donning and doffing of PPE, which is actually shown in the slide set here. So have a read of this public health guidance, which is quite a useful guidance for you to go through. Towards the end, I would say that it is very important for us all to protect ourselves and our families. And it is a difficult time, and people are anxious around this, but there are certain things we can actually do to reduce the risk of us getting infected or reducing the risk to our own families. So always practice social distancing at work, whether you're doing a board round, ward round, MDT, etc. A lot of things are already happening on online these days anyway. But if you are going to work, bring a change of clothes to work. That's what I'm doing at present. I change at work. I bring the used clothes in a cloth bag back to work, back to home, and put them straight into the washing machine at a high temperature. Washing hands and arms very frequently at work with soap, and try not to touch your face too many times, or face or nose or eyes. And before you meet your family, when you come home, I normally tend to just go straight into the shower after putting my clothes in the washing machine. In terms of washing hands, I've seen a lot of videos, but this video, which the link is here, it's one of the best videos that I've seen in years. So have a look at this video. Don't forget that your belongings, like your phone, like your keys, like your door handles, like your stethoscope, like your office bag, etc., or name badge, etc., will have a lot of exposure to the virus and various things. So try and keep that stuff outside in a box, if you can. Look after your own mental health. There is a helpline. There's a local helpline from MPFT, but there is also a national helpline as well for all professionals. And in MPFT, we are also establishing some wobble rooms, which will be useful for you to use. And just general things like sleep well, exercise well, eat well, and try and re-energize yourself. The current emphasis is on flattening the curve, which means the less we get exposed to other people, the less we expose other people. And as we flatten the curve, there is a reasonable chance that we will delay the progression, we'll delay the surge and the peak, and in time we will infect lesser number of people. And that's why the policy around social distancing, to stay at home, protecting the NHS and save lives comes from. And we are already seeing some positive effects of this. There are some resources which you could use. And before I conclude, because it is 1 hour now, I think the key things which are also reassuring is that around 80% of patients will have a mild illness. So be cautious, but do not panic. Testing, isolation, PPEs are key issues. Regular updates are available both nationally and locally. So read the evening COVID bulletin, which comes through the MPFT wide email networks. Keep checking for NHS updates as well. Look after yourself. They are very, very important, as well as your family. But support your colleagues as well. We will all feel low at some point in time. Um, and remember, this isn't going to last forever. Better times will be back.